So today we're going to talk about aortic stenosis and when it gets ugly, or how not to kill your patients with critical aortic stenosis, which is probably good. And if we have time, we'll get to a few other decompensated valves as well. So a few take-home messages for you to remember if this is all you remember. You can't fix a mechanical problem with medicines. So if someone has a pinhole for an aortic valve, there's no medicine that you can give which is going to alleviate that issue. You're only doing temporizing measures until they get a final fix, which is going to be a surgical or structural fix. If you have symptoms for really any valvular disease, it's time to replace the valve. That is very, very important. For aortic stenosis, the day that you start having symptoms, your mortality starts to increase. So we replace the valve as soon as we have symptoms in aortic stenosis. This is probably the most important one. It should be red and highlighted and blinking at you. Aortic stenosis is a preload dependent state. You have a ventricle trying to pump against a little tiny pinhole. If you have an aortic valve area of 1 centimeter squared, that I can't even make my fingers that small. You need as much preload as possible to get through your cardiac circulation into the left ventricle to try and pump it out of that aortic valve. If you acutely decrease the preload by giving what, for example? What would acutely decrease your preload that we give all the time? Yeah, I know my CCU team knows because we talked about it today. If you give nitroglycerin to someone with critical AS, that's a great way to kill them. So don't do that. Preload dependent state. Also, if you diurese them aggressively and you drop their intravascular volume, you will impair their cardiac output because they don't have enough volume to get through the circuit through that tight aortic valve. So don't do that either. The mainstays of treatment for aortic stenosis: diuresis, afterload reduction to try and get as much fluid that you can out of the LV and into the circulation, and avoid large swings in your hemodynamics because that will really cause problems with them. And this is the words of one of my mentors that I trained with, Gary Gerstenblith. He would always say the enemy of good is perfect. If you have someone who is good and they're okay, don't get cute and fancy and try to make everything perfect. For patients like this who are very tenuous, you will make them worse. So sometimes with aortic stenosis, you have to go with good and not with perfect. This is a nice lunchtime picture for you of calcific aortic stenosis, which is most of what I'm going to spend my time talking about today. This is a disease of the elderly, so people in their mostly 80s and 90s that have atherosclerotic risk factors are the same risk factors for aortic stenosis. You get all this chunky calcification, thickening of these valves. This is what it looks like when they're actually doing the operation in vivo. See all this chunky calcified atherosclerotic debris, and that basically gives you rock piles instead of nice thin leaflets. That's why it's difficult for this valve to open. I'm going to tell you about my favorite patient that I've ever taken care of because she perfectly illustrates what can happen with aortic stenosis. So we call her the huckabuck because when I asked her one day, "So how's your day today?" she said, "Whoa, they took me downstairs and they did the huckabuck." And I have no idea what that means, but henceforth she's been known as the huckabuck. Nobody laughed. That was funny. Okay, maybe I'll get you with something else. So she's 85 years old and she is the matriarch of her family. She doesn't like to see doctors at all. She came into the hospital with dyspnea on exertion while walking to church, and she had profound lower extremity edema. No complaints of chest pain, no palpitations, no orthopnea, etc., etc. And importantly, no syncope. So just dyspnea on exertion, lower extremity edema. She had been hospitalized once before for some acute exacerbation, and at that time in 2005, so this story is back from 2011, so 6 years earlier, she had an aortic valve area of 1 centimeter squared. What do you think? That's normal or abnormal? Yeah, that's called critical aortic stenosis or severe aortic stenosis. Normal should be greater than 2, greater than 2.5. So that's a very tight valve. Back 10 years or 6 years prior. And at that time, she hadn't wanted to do anything further. Her gradient, pressure gradient across the valve was 18 millimeters of mercury. We're going to talk about what that means, but usually when your aortic valve is open during systole, should you have a pressure gradient across the valve? No, you shouldn't have any, right? It should be wide open so that this pressure in the left ventricle equals the pressure in the aorta. So she had a gradient. It turns out this isn't that big of a gradient at the time. So when she presented, she was in atrial fibrillation. She had good blood pressure, tachycardic. She got 2 liters of nasal cannula. She had this righteous murmur. So someone tell me, what's the murmur of aortic stenosis supposed to sound like? What do you learn? Go ahead, John. I hear you. Crescendo, decrescendo, systolic or diastolic? Systolic murmur, and you hear it best where? So you hear it left, usually the aortic space is usually on the right upper sternal border, and it radiates where? Can radiate up to the carotids, and that's actually important. Quick quiz. What is the most sensitive physical exam finding for severity of aortic stenosis? What's the one thing, if you're going to pick when you're listening, that you hear or don't hear, whatever this may be, and you say, wow, this might be critical? What is it? Okay, we'll vote. You're very interactive. How about the loudness of the murmur? Who says that's the most important thing in physical exam? Okay. Who says the characteristics of S2, the second heart sound? Raise your hand. Okay. Who says where it radiates and how far it radiates? Raise your hand. Whew, I have 3 entire people who are willing to vote. Okay, this is poorer turnout than in America for voting. So it turns out the most sensitive physical exam finding for the severity of aortic stenosis is the absence of an S2. So when you hear and you don't hear that second heart sound, that suggests that it is so tight it barely moves, so you don't hear it when it closes. So when you hear absent S2 with the crescendo-decrescendo murmur, that tells you that they probably have critical AS. Turns out she had an absent S2. Okay. Her JVP was about 12 centimeters of water, and she had lots of crackles and wheezes in her lungs. We got an echo, and she now had depressed EF, 35%. Her aortic valve area, 0.6 centimeters. That is one of the lowest I've ever seen. But the gradient across it was 40 millimeters. That's a high gradient. That means that when her LV squeezes, her LV has 40 millimeters extra of pressure than what the aorta sees, because it's trying so hard to get the fluid out of there. And that 40 millimeters is the cutoff for severity of aortic stenosis. So all this is telling you, her physical exam, her presentation, her echo results, all of this is telling you she has severe aortic stenosis. So, let's see if I can make this. I want to show you, because it's fun and awesome, a little bit about the echo. So, if you've not looked at echoes before, and this is the left atrium, the left ventricle, the mitral valve between them. This is the aortic valve coming out of the left ventricle. That's the right ventricle over there. This is her aortic valve. And just by looking at it, see how the mitral valve moves and it's kind of floppy and nice and thin? The aortic valve are rock piles, and they literally barely open. So just from looking at this, you can tell she's got pretty bad aortic stenosis. So what we ended up, spoiler alert. So she had a lot of other medical comorbidities. She's 85 years old. She's got atrial fibrillation. We thought she may have interstitial lung disease as well. And so she was a pretty, how good of a candidate do you think she was for surgery? Pretty poor, right? If she comes to your clinic and you're doing a pre-op evaluation, you're going to say that she's high risk for a high-risk surgery. So it turns out that one thing we're able to do in the modern era is to do TAVR. Has anybody heard of TAVR before? Know what that is? Yes? It's sweet. So TAVR is transcatheter aortic valve replacement. And so in patients who are at very high surgical risk, we can take these valves. This is the Medtronic core valve. This is what it looks like. It's just chicken wire, and this is made from pig or cow pericardium. So we make leaflets. It's inside this chicken wire. It gets crimped down really small, loaded into a catheter. We go up just like we're doing a cardiac catheterization, load it across the aortic valve, and deploy it. So once you've deployed it, it ends up looking like this. Here's your aortic annulus, where the native valve is. Remember, the coronaries are right after that, so you have to have room for the coronaries to still perfuse. And it sits in the aorta like this. It gets endothelialized. Have a nice day. It's pretty sweet. It's self-expanding, so once you deploy it, it actually keeps expanding to kind of nestle itself down in there. And this is FDA approved for extreme risk patients, of which she was not extreme risk, but there are other people who are. This is the other kind of valve that's available. It's called an Edwards-Sapien valve. This is the one that was in the Partners trial. If any of you are familiar with the Partners trial, that's been recently a lot of attention. So it is not self-expanding, and it has just a little bit different configuration. Similarly, loaded onto the catheter. That's literally what it looks like when you put it into their artery. So she was approved to be in a research protocol for core valve, high-risk group, and I just want to show you because it's awesome. This is what we do in the cath lab. So here you're looking, here's the spine, here's the aorta coming up, and here's her heart over here. Anybody know what that is? Bonus points? Oh, I heard it. Go ahead. Yeah, so this is a temporary pacemaker. I know it's temporary because it's coming down from down below, and there's nobody who has their pacer box down here, okay? So this is a temporary pacemaker that you need. The reason you need that is because when it's time to deploy the valve, you pace them rapidly, because you don't want the heart squeezing while you're trying to fit the aortic valve in there. So you pace them rapidly for a few beats while you deploy the valve. Here we've got a pigtail up in the aorta. We're squirting dye, and you can see, we'll do it in a second again, She has AI as well. You see that reflux going back into the left ventricle? You see her coronaries coming off here, and you can see the aortic valve there. So that's how we get the shot to set us up. And then here's the whole device, so it's loaded onto a catheter. It also comes up the aorta from the femorals. Here's a TEE probe, that's it, because we're going to look at the images on TE as well. And now, with this pigtail and this wire, we've crossed the aortic valve. That's pretty sweet, right? And we have this valve that's clamped down, and we're ready to deploy it. So we've got it in position. And then you pace the heart rapidly, deploy the valve with a balloon. You're going to open it up in there. So here's how it looks halfway through. Oh no, here's it going. Sweet. So different valves have different techniques, but essentially you start to deploy it by kind of taking off what was keeping it in place. Here it's halfway deployed, so you're making sure that you're still over the annulus. Eventually you deploy it all the way, balloon it open, and you have this valve sitting in there. This is why cardiology is so awesome. And now here we have a pigtail. Now we're up, we're not in the LV anymore, so our pigtail's up in the aorta, fully expanded. This is the core valve. And you can see that there is a little tiny bit of AI. So ready? Some of it goes down into the LV. You see that? A little bit of time. But that's not very much at all, because you can have some blood that leaks around the sides of this valve, and it looks pretty awesome. Her hemodynamics instantly improved in the cath lab, immediately. So this is used with permission. So this is her before, looking all sick and in the hospital, and that's her coming to clinic like the foxy lady that she is. Doing great. Last time I saw her was about 3 months ago, and she's doing absolutely fantastically. So this really gave her back her entire life. So that was a great story that I told you about. Now let's get back to aortic stenosis and what you can do acutely in the inpatient setting for people. So how do you make a diagnosis of aortic stenosis? Give me some exam findings. We've talked about most of them, but go ahead. Anyone? What do you listen for when you're listening for aortic stenosis? Systolic crescendo decrescendo murmur, we already heard that radiating up into the carotids, good. Absent S2 we talked about. What about the rest of your exam? What else might you find on your physical exam? How about the pulses? Pulses parvus et tardus, sound familiar to anyone, right? So the LV is trying to pump all this fluid out, and that delays the carotid upstroke and makes it a little bit fainter. So pulses parvus et tardus. And then you might have all your signs and symptoms of heart failure because you have this obstruction at your LV outflow. So they get all the same things that people with systolic heart failure get. They get pulmonary edema, lower extremity edema, jugular venous distension. Okay? So we talked about all of those things there. How about symptoms? What are the classic, there's 3 classic symptoms for aortic stenosis. Syncope, good. What else? Chest pain or angina, good. And one more? Dyspnea. Good. So I use ASD as my mnemonic. And the reason I do that is because these are in order of their progression to death. So angina, not good. Syncope, worse. Dyspnea, meaning that they have heart failure symptoms, right? So they get dyspnea on exertion, they've got pulmonary edema. These are in order of the prognosis. This gives you 50% mortality at 2 years. So as soon as you start to have these symptoms, you have to do something about the valve. And then this is more for cardiology fellows, but for you to know when you read those echo reports, look at this severe category. If you have an area less than 1, that is severe. And if you have a gradient of greater than 40, that is going to be severe aortic stenosis. So those are the ones for you to keep in your mind. So what if you have someone who's asymptomatic, you just find that they have moderate aortic stenosis on their echo. You heard the murmur, you got the echo, you've taken a great history, they have no symptoms. In the outpatient world, how would you manage someone with moderate asymptomatic aortic stenosis? What would you do for them, doctors?
Make sure get echo once a year.
Okay, good. So we'll talk about frequency of echo screening. What are you looking for on the echo?
Progression.
Absolutely. So that's important. What else might you do for them? Would you have any medical management for aortic stenosis? Good. So afterload reduction. And what agents would you feel comfortable using? Or classes of medicines? Yeah. So beta blockers are our mainstay of treatment. Absolutely. So the main thing is afterload reduction. And the main one we want to use is beta blockers. You can use other things. So you can use ACE inhibitors, you can use calcium channel blockers, but you need to be careful with vasodilators for the reason we talked about before. They're preload dependent. If they're moderate, they're not going to be as preload dependent as the severe ones. So you can basically use what works to get their blood pressure down, but we like beta blockers, okay? So in terms of risk factors, you might think, well, this is an atherosclerotic disease, right? All of the risk factors for coronary disease are the same risk factors for aortic stenosis. They've done the study and showed that statins do not slow the progression of this disease. So while they should be on it because they probably also have other atherosclerotic disease, it doesn't slow the progression, unfortunately. People used to always worry about endocarditis prophylaxis anytime that you have structural or valvular heart disease. In the most current recommendations, you don't have to do that for someone if aortic stenosis is their main valvular problem. And then most of these people have other cardiac disease. So most of them have coronary disease, AFib, hypertension. So you treat all of those other things just like you normally would. And then to get to your echo screening, so if you have mild stenosis, you can just go every 3 to 5 years as an echo is fine. Moderate, every 1 to 2 years. And someone who is severe, so with that area less than 1, but no symptoms, you probably want to do them every 6 to 12 months to look for progression. The reason why is this. Do you guys remember learning in medical school that aortic stenosis, the mortality curve is flat like this, and then it says day of symptoms, and the mortality drops? Anybody remember that curve? It's been around forever. Do I have it next? No, I don't. So the point is that you want to replace their aortic valve the day before they have symptoms. It's not possible. But you want to get as close as you possibly can. So the day their exercise tolerance starts to go down and you don't have any other explanation for it, that's the day to refer them for either surgical or transcutaneous replacement. And here's what I was showing you before, that if you have angina, then average survival is 5 years. Syncope, average survival is 3, but heart failure symptoms, dyspnea, your average survival is 2. So with severe AS symptoms, your mortality is about 25% per year. And then we just said this, heart failure is an even worse prognosis. So you really have to be watching and carefully screening for those things. I'll tell you anecdotally, not even anecdotally, but in the real world, most of the time people with severe AS, what ends up happening is they don't have symptoms if you just ask, do you get any chest pain? No. Do you get short of breath when you walk? Not really. But when you ask them, do you walk less today than you did 6 months ago? They'll say yes. Because subconsciously they limit their exercise and they limit their activity because their body knows that they can't handle it. So I'll usually say, okay, so right now we're in fall. I'll say, go back to like winter time of last year. Were you walking further back then than you are now? And pick some time point they can remember, like a holiday. What were you doing last Christmas? And if they know that their exercise tolerance has decreased, that's usually the first sign that they have symptoms. Okay, so now let's talk about the pathophysiology of the symptoms that they get. So why, when you have aortic stenosis, are you going to get angina? What is the reason behind that? Somebody tell me. Like it's typical angina, exactly what you think. Substernal chest pressure can radiate to the left arm, worse with exertion. What would be the pathophysiology of that? Any takers?
This LVH.
LVH can have something to do with it, yes.
And so the heart gets bigger, but the flow gets, the bigger heart gets less blood.
So that can be part of it, and that's going to be most important when you get to the dyspnea factor. So the reason, angina means decreased coronary perfusion. So why might you have decreased coronary perfusion in these people? So basically, they have this tight valve, and remember the coronaries are right after the aortic valve. So for blood to get down the coronaries, it has to come through the aortic valve. And you have just decreased because you have less blood getting out through the aortic valve. Also, what happens in the elderly? So in you or I, we have, hopefully, nice, compliant aorta. So let me back up. During what phase of the cardiac cycle do you perfuse your coronaries? Systole or diastole? Diastole, good. So diastolic blood pressure actually is made up of the reflected pressure wave. So you get the squeeze of your heart, the pressure goes down the aorta, hits your vascular bed, and a lot of it reflects back. And you or I, because we have really nice compliant arteries, that happens during diastole. So my diastolic blood pressure is actually augmented by this reflected pressure wave. What happens if you have a really stiff, calcified aorta like a person who's 85 years old? Well, that pressure goes down and pings back right away because it's so stiff it doesn't comply and absorb the pressure wave. So have you noticed that your older patients all have really wide pulse pressures even if they don't have AI? This is why. Because all of that reflected pressure wave comes back during systole. So they have even lower diastolic blood pressures and therefore even lower coronary perfusion. This is really important because Let's say you have a patient who comes in, he's 85 years old, hypertension, hyperlipidemia, 100-pack-year smoking history, comes in with exertional substernal chest pain, and now he's got chest pain at rest. What is usually your first move for that patient? Chest pain, go. What are you going to do? EKG troponins. I'm still having chest pain, doc. What do you want to treat me with? Okay, good. That's exactly the wrong answer. So we all give nitro for chest pain. Why would nitro be wrong in a person who has aortic stenosis? Because you could kill them. And it turns out that aortic stenosis can present with angina that sounds exactly like coronary angina because it is coronary ischemia. So in my opinion, it is malpractice to give someone nitroglycerin until you have put a stethoscope on your chest. You might hear a murmur. A lot of people have murmurs. But if you hear that absent S2, you hear this raging carotid, or this raging crescendo murmur that radiates up to the carotids, why don't you hold off on giving that nitroglycerin for now, okay? This is a really, really, really important point. I've seen it happen time and again. Okay, next, syncope. So how do we get syncope? This is pretty straightforward. You have decreased cerebral perfusion because of the tight aortic valve. Most of these people also have carotid disease. What happens when you also try to get their blood pressure perfect? Do 85-year-olds like to have a systolic pressure of 120? Not usually, not if they have long-standing hypertension. So sometimes when we're trying to make things perfect, we hurt them here. So that's why we get syncope. And then lastly, dyspnea is a little bit of the harder one to explain. But basically, you have a gradient across this aortic valve. That leads to hypertrophy, just as you were saying. So the heart is under this high pressure, so it builds up. The hypertrophy of the heart is going to delay the diastolic filling. And then you have decreased time for the atria to get into the left ventricle, so you end up with fluid overload and dyspnea and pulmonary congestion. Okay, does this make sense to everybody about the pathophysiology of the symptoms in aortic stenosis? Yes? No? Okay, good. Yes, great. So let's talk about their hemodynamics for a second here. So this is a normal person. I hope this is me. Blood pressure in the aorta, 120/80. Blood pressure in the LV, this is during systole, so the aortic valve is open. Your systolic pressure in the LV should be the same as the pressure in their aorta, right? Wide open, there should be no difference between those two things. The pressure is lower in here during diastole than in the aorta for the reasons we just discussed. If I were to put a catheter into your LV, and then also have a catheter in your aorta, like what I just showed you, we do this all the time. Here's what the tracings would look like. Everybody recognize this aortic pressure, or this arterial pressure tracing? It's just like an art line, right? Dichrotic notch, that's when the aortic valve closes. So here's what the arterial pressure tracing looks like. This is an LV pressure tracing. The diastolic blood pressure drops lower. But in a normal person, these are exactly superimposed during systole. They have the exact same peak pressure. Make sense to everybody? Here's what happens when you get aortic stenosis. So now you've got a rock pile. Got your nice LVH. The LV has to mount huge pressures to try and push through that rock pile. So even though your systemic pressure might be 110, the pressure inside your ventricle is 200. So it's really squeezing. So if I do the same thing and I put a catheter here, not really recommended to put a catheter across that rock pile and cause a stroke, but okay, if I do it, and I put one here, here's what I'm going to see. Here's my aortic pressure tracing. It has that delayed upstroke. That's pulsus parvis et tardis. And my LV pressure gets much higher during systole because I'm trying to overcome this barrier. So now I get this huge gradient between the two. Okay? In the cath lab, this is what it ends up looking like. And we use this measurement, the peak to peak, to tell us how severe the aortic stenosis is. It's actually really cool and fun to do. As soon as you do a TAVR, this goes right back to being normal, and it's very satisfying. So the mainstay for symptomatic aortic stenosis is you have to treat them. And surgery was the only thing that we had. This graph is about as old as me, and it looks a lot older than I do, if I do say so myself. So here's normal individuals. You guys are a tough crowd today. Okay. Sorry, so here are people who are not operated on, who have symptomatic AS. And this is 2-year mark, and these guys were really bad. More than 50% of them were dead at the 2-year mark. Here's people who get surgery. You have your initial decrease in people who are alive because there's always some surgical mortality. And then look at that. Great curve. This difference you almost never see in anything in medicine. So surgical correction of aortic stenosis, no doubt about it, that's the gold standard of treatment. The timing of operation, as I mentioned, is the day of symptom onset. So when you're following patients in your outpatient clinic, you've got to think about this and make sure that you're sending them for surgery at the appropriate time. So, woo, this is busy, but these are the guidelines from the American Heart Association and ACC. So essentially, if you have symptoms, yes, you get surgery. There's no question about it. Who else gets surgery? Well, if you need a cabbage for some other reason and you have pretty decent aortic stenosis, you're going to get surgery. If you don't have symptoms, then there's some other ways that we can tease out whether or not you have severe or progressive aortic stenosis. So that's things like you can put you on a treadmill and see if you get symptoms. If you get symptoms on a treadmill, that turns out you have symptomatic AS, you get surgery. And that's all I'll say about this. This is just to show you some cool data about what's happening in modern medicine, which is really exciting. So the Partners trial, have you guys heard about Partners trial? Does that sound familiar somewhere in there? So Partners is pretty revolutionary. This was published now, I think, 2011. And basically they took patients who you couldn't operate on them because their kidneys were gone and they couldn't walk and they had COPD and were really high risk to not come off the vent. So basically not operative candidates. And they randomized them to standard medical treatment. What's the medical treatment for severe aortic stenosis? Nothing. There's really nothing you can do. And so people got standard of care, or they got that percutaneous valve that I showed you about. And they showed a huge reduction in mortality, 26.8% absolute reduction in mortality for people who got the TAVR. That is one of the biggest differences that we've seen in modern medicine, so that's really exciting. You might say, well, I'll ask you, what do you think would be a risk of someone who's getting a valve crunched open on a very crunchy, nasty aortic valve? Stroke is a huge worry that you have. You might also think about aortic dissection. There's a couple other things, but that's the biggest concern. So you have to say, okay, well, this many people, you saved them, but how many of them did you give a stroke in the process? So stroke was much higher in the TAVR group, but when you combine mortality and stroke together, you still get an absolute reduction of risk of 23%. That is really good. Based on this was the Edward Sapien valve. This is now approved for inoperable candidates can get TAVR. We do them right across the street at Jewish Hospital. So when you're in the NICU with someone with aortic stenosis that's decompensated, please call cardiology. But we can remember this and we can think about doing TAVR for these patients. So there's several different risks that you need to be aware of. So stroke, we talked about that. Dissection, right? You're disrupting the intima of the aorta, so that can happen. Paravalvular leak. I showed you when I was showing you Mrs. Huckabuck's films that she had a little bit of leak around the outside of that valve. If that is serious, it gives them a worse overall prognosis. And it's worse in the Sapien. Those are the smaller ones I showed you because they don't have that whole apparatus to kind of hold them in place. So that's kind of a known phenomenon. Then you can imagine you're expanding this valve, and you know what's right next to the aortic valve? The AV node. It's pretty much right there. So that's why when you have someone with aortic valve endocarditis, you're watching their PR interval, right? Because you want to make sure that they're not getting AV node involvement and getting an abscess. Well, here you can get this AV block after the surgery, so they all can tend to come out with temporary pacemakers, and then we hope that they don't need one. Also, they can get left bundle, which also gives them worse prognosis overall. Some people need the pacemakers, and then you can also always have bleeding. You're going into the groin of these old people who are frail and often on anticoagulation. So now, class 1 recommendation for TAVR in inoperative people, and then there's the next worst are people who are borderline operative risk. It's now approved as a class 2A indication for those people who are high risk but not extreme risk. You don't need to know all of that, but just keep in mind that if you have someone that you're like, well, they could never go to the OR, we can do some pretty cool stuff for them, and insurance will pay for it. So let's do one management case, and then we'll be done. So you have an 80-year-old man. Oh, we already did this. Okay, give me your differential. For an 80-year-old man, hypertension, diabetes, tobacco, chest pain with exertion, now at rest. What's your differential diagnosis? Yeah, it is. Now it is. Good. What else is on your differential for that person? Angina, right? Crescendo angina or maybe even unstable angina. So I think I've made the point here. So if you'd like to kill patients with critical AS in the hospital, I want to give you a list to write down if you would like to do this, okay? Give nitro to everybody with chest pain. Give pure venous vasodilators like nitroglycerin and hydralazine and reduce their preload on purpose. Aim for this perfect blood pressure in the 80-year-old. Diurese them 3 liters a day as fast as you can. And then leave them in AFib at 140 beats per minute because they love that. No, wrong. Don't do it. That's a good way to kill people. I don't want to see you do that. So here's how we not kill patients. This is the main thing you take home. Someone who has aortic stenosis, all you need to remember are these things. Examine before you give nitro. If I catch any of you popping nitro in a patient without listening to their heart first, I will kick you in the shins. Actually, I'll give you nitro and see how you like it. A lot of nitro. Okay. I have a good story about that I may have time for in a second. Remember, aortic stenosis is a preload-dependent state, so be careful about how you play with their hemodynamics. Give them afterload reduction, but do not aim for normotension in the elderly because you will give them a stroke if you try to get their blood pressure to be perfect. Diuresis if wet, but go slowly and gently. These are old, fragile people, so do a liter a day and watch them closely and don't rock the boat. If they're really sick and you're trying to do all these things, but their blood pressure is tanking and they've got tons of pulmonary edema and they're in a really bad situation, you call the CCU. We can do things that are kind of awesome, like we can put balloon pumps into people, which will basically help to decrease the afterload so that they can pump more during systole. And we can even do an emergent valvuloplasty. That's where we just blow up a balloon in the aortic valve real quick, kind of fracture off all that calcium, and blow it up for a little while to give you a little bit better output while you can try to get them over their other illnesses. So there are things that we can do to temporize them. And then one note about AFib. So people with aortic stenosis, again, they're preload dependent. So you got to get as much volume into the LV as possible. When you have AFib, what happens to your atrial contraction? Yeah, it gets really wonky and kind of like jello. So you don't have any coordinated atrial kick, as we like to call it. A lot of older people, have you learned this? They're dependent upon their atrial kick because they have stiff ventricles. The ventricle is actually supposed to relax and suck in the blood as it relaxes. People who have stiff ventricles, they don't do that. So they need the atrial kick to get the blood in there. When you lose the atrial kick in the elderly, then you lose a lot of your preload, and that really hurts people with aortic stenosis. So sometimes AFib can be really detrimental to these people, and we'll often consider getting them out of AFib, but we can help with that, so don't do this at home by yourself. Okay. I'm going to skip all of these things. Well, just one quick word to say. So you might say to me, okay, you could imagine that someone has this tight aortic valve, but all of the pressure that we measure going through it depends upon the pressure that gets into the system, right? So what if you have a ventricle and your EF is like 10%, it doesn't pump well? How can you tell if they have bad aortic stenosis or not? Well, go ahead. You have an answer?
Yes.
Good, you can. So basically, you want to try to increase how much blood is going through that valve and see what happens to the pressure gradient. I'm going to say no more about that for now. Okay, this is an important part of aortic stenosis. Who knows what Hades syndrome is? Or Hades syndrome, however you want to say it. Go ahead.
They get like GI bleeds as well as when they have aortic stenosis. They have some metalloproteinase problem.
Yeah, that's right, absolutely. Have you guys taken care of these people who have aortic stenosis and come in with GI bleeds? Anybody taking care of someone like that? Okay, good, I'm the only one. So here's what happens in Hades syndrome. They get angiodysplasia of their GI tract. So basically they get AVMs all over the GI tract. They also, lucky them, get an acquired von Willebrand's factor deficiency. What happens is you have this turbulent blood flow through the stenotic valve. So the blood's not zipping along nicely. It gets turbulent as it goes through the calcified aortic valve. This disrupts your von Willebrand factor multimers, and that leads to increased platelet clearance, and therefore increased GI bleeding. So you have, for some reason, they form these AVMs. We don't understand why. Plus, you get a von Willebrand's factor deficiency on top of that. That's a perfect setup for bleeding. This is what it looks like when they do the scope. The cool thing is that when you fix their valve, this all goes away, which is really awesome. Quick quiz, who else in cardiology get AVMs like this in the GI tract? Anybody know? Yeah. So patients with LVADs who have continuous flow, there's something about the pulsatility that we need. So they also get this. Okay. I think we're going to stop there, right? 1:15 is my time?
Yes, you still have more time if you want.
I still have more time. Okay, let's do a quick, yes. People get endocarditis in this hospital, right? Do they? Yes, good. Mostly right-sided, I'm assuming, yeah? Anybody seen aortic valve endocarditis in their life? Yeah. Did it end well? No. How did it end? Okay. So let's talk about one of the dreaded complications about aortic valve endocarditis. So if you have a bacterial infection eating away at your aortic valve, it just becomes incompetent and non-existent. So you can have acute aortic insufficiency. You can also get acute aortic insufficiency in what other situation? Anybody know? Yeah, good. So if you have a type A or retrograde dissection that's coming from the aorta down, it can totally disrupt the architecture of the aortic valve and give you acute aortic insufficiency. How can you fix acute aortic insufficiency? Yep, sir. Good. That's right. There you can't. So this is really, it's almost always fatal if you see this. Basically, you can try to give them some after lobe reduction and give them an inotrope to try and whip that LV, but they have to go immediately to the operating room. So I'll tell you a story from when I was an intern. So my first month in the CCU as an intern, it was in September, and all of the other physicians were off the floor, which meant, I was just there as an intern, so that wasn't really reassuring. We had a man who had staph endocarditis of his aortic valve, nicest man in the world, and he was just waiting for surgery because he had a brain bleed, so we had to wait some time until he could go in the bypass pump. And all of a sudden, I'm sitting there writing my note or who knows whatever, and a nurse comes running over and hands me this EKG, and she's like, room 27 is having chest pain. And I look at the EKG, which is the worst thing I've ever seen in my life. So it's ST depression everywhere, AVR is elevated, and it just looks terrible. I go in his room, and the man is breathing 50 times per minute in total distress, hypotensive, rapidly decompensating, and I'm leaning in, and the first thing I said was, call the fellow, because they were all gone in the cath lab, because I didn't know what the heck to do. And I leaned over to him and I said, sir, we're going to help you. We're going to help you feel better. Yeah, he died basically instantaneously. So he had had acute rupture of his aortic valve because he had an abscess eating away slowly at his aortic valve, and he just ruptured right in front of our eyes, and there was no way that we could save him, and he died. This is a really great, uplifting way to end the talk. But one thing I do want to tell you about that's important. Anytime you have an acute valvular problem, the murmur is absent. Does anybody know why? So if I were to listen to that man, I would not hear aortic insufficiency. And the reason why is, what does a murmur come from? When you hear a murmur, what are you hearing? Turbulent flow. And so you have to have some pressure differential in order to hear a murmur. If the blood is just a column right in between two chambers, there's no flow and there's no pressure gradient and there's no murmur. So when I just all of a sudden, boom, open up my aortic valve, the pressure in my aorta and the pressure in my ventricle are going to be what? They're the same. So there's no murmur for me to hear because the pressure is acutely the same. That's different than if it happens over time, but that's the same thing for acute mitral regurg that you might see in the setting of an MI. You might not hear it because you need a pressure differential. Okay. Great, so that's that. And one more quick word, because CCU team are now experts on how to treat mitral stenosis because we have a case right now. So mitral stenosis in the current era is pretty rare. What does it usually come from worldwide? Rheumatic fever. So we're pretty good at preventing this now, but if you do practice overseas where they don't treat as well, then you may see this. We, right now on service, have mitral stenosis that's because of a malfunctioning prosthetic valve. So what happens in mitral stenosis, here's the way that I remember it. The only time you ever find young people that have mitral stenosis is when the women get pregnant. So that's how I remember about how to treat mitral stenosis. So what happens in pregnancy to your blood volume? It increases. And what happens to your heart rate? It also increases. And so those things are both bad for mitral stenosis, and here's why. Your LV is dependent upon filling, and it takes longer, right? Because now you've decreased the valve area, so you can't get as much fluid through. It needs time. And we've talked about this before. Diastole, when you get more tachycardic, is your diastole a relatively longer or shorter amount of time in the cardiac cycle? I didn't ask that very well. As you get more tachycardic, the amount of time, relative amount of time you spend in diastole shortens. So normally, at a normal heart rate, you spend 2/3 of every cardiac cycle in diastole. The faster you get, the less time you spend in diastole. So more tachycardic, less diastole, less time for LV to fill. And that's very important. Circulating blood volume is obviously bad if you have mitral stenosis because it can all end up in your lungs. So how do we treat mitral stenosis? It's pretty simple. We need to give them beta blockers to slow their heart rate for diastolic filling time, and we need to get rid of the blood volume to alleviate pulmonary edema. That's pretty simple for the medical management of mitral stenosis. Okay. I'm going to stop there. We'll talk about acute MR in another time. So the take-home message from the valve part of this talk, you can't fix a mechanical problem with medicines. Replace the valve if you have symptoms. That's for any valvular disease. Aortic stenosis is a preload-dependent state. Have I said it enough? Do you remember now? For aortic stenosis, diurese, after lobe reduction, and avoid hemodynamic shifts. Lastly, but not least, the enemy of good is perfect. Any questions?